Thanks for inviting me. Thanks for having me. My correct title's up there, but that's okay. It changes weekly at Mount Sinai. And I've got the easiest job of the day: critical limb ischemia treatment, why we should treat it. Save the legs. Okay, goodbye. So let's see. Let's make sure we get this. Spectacles. And show. Yep. Sorry. Okay. Basically, a couple quick things. We're going to focus really here on critical limb ischemia and more so on the idea of tissue loss. I mean, we've seen a lot of cases that talking about, Fontaine 2B type cases, but why do we do things to help save these patients? And at the end of the day, I spend a lot of time healing wounds as well as revascularizing folks. So remember, the original definition of critical limb ischemia is as you see it here: chronic ischemia with arrest pain, nocturnal recumbent pain, or ischemic skin lesions that may include ulcers and frank gangrene, and specifically did not include diabetic foot ulcers. Actually excluded patients with diabetes when this was first written. Now, diabetic foot ulcers are very different. And it turns out that probably about 50% of those are mixed neuropathic and ischemic. So it's just kind of keeping a mindset of what you're treating when you're treating this. And probably diabetes, and this is actually hard data to find, but diabetes that has just ischemia with no neuropathy that's significant is probably only about 15% of your foot ulcers. So let's go forward. There are certain biases, but one place to look at these biases is actually looking at outpatient wound care data, which is not necessarily where your interventional cardiologist is often going to look particularly. But where do these ulcers occur, and what are the real things that are seen in the outpatient? Well, Carolyn Fife's a person very well known in the wound care world who looks at a very large consortium of wound care centers. Now, a lot of those wound care centers at the other end of their vascular intervention list, they actually don't even know what they're sending to, whether it's a vascular surgeon, IR, or interventional cardiology, and it shouldn't really matter, right? But with that in mind, most outpatient wound centers actually don't see pure CLI patients because they stay in vascular surgery practices quite a bit. Only about 1.5% of patients seen in the outpatient wound care center is a pure arterial path. Most of them are actually diabetic foot ulcers. So diabetic foot ulcers account for 12.8% of those patients seen. So again, what we're treating and what we're doing is a little bit different. Of note, the CLI hemodynamic criteria, however, were never intended to be applied to diabetic foot ulcer patients. And one thing to keep in mind is your diabetic patient probably does have somewhat different parameters as far as acceptable ABIs, TBIs, TCPO2, near-infrared spectroscopy, or what other method people are using to identify it. The point here is that there is overlap, but they are not the same thing and should be treated, therefore, differently. This is actually a little study we did on a different type of patient, a patient you don't think about too much, but patients with venous leg ulcers. And venous leg ulcers, Bill Marston, who's the ex-chief of vascular down at UNC, he wrote a very nice paper back in the sort of the turn of the century that showed that you can heal venous leg ulcers if they have an ABI as low as 0.5. But in this day and one of the things is back in that time period, when I was a fellow before the 2000, you never would do a bypass at all in a patient with venous disease because they'd swell, they'd become terrible, it was a complete mess. But our endovascular techniques have made that hugely different. So a patient now who has a poor ABI, they will progress very nicely. So what we fundamentally showed were patients who had venous leg ulcers and ABIs that were less than 0.5, and we had wound closure rate of about 23%, wound area reduction at the end of 36 weeks of care. And that's epitomized here by, I'm having trouble with this mouse today. Sorry. That's epitomized by this group of patients here not doing well. Well, after we revascularized this group of patients, we moved their ABI up significantly, almost to normal with interventions. Most of these were SFA interventions, honestly. They didn't warrant intervention just based on their symptoms, but on their wound they did. And you can see that their closure rate went down to about 10 weeks till they closed. So venous leg ulcers with bad ABIs might be a sweet spot to intervene on some patients. So this is mixed arterial venous disease that you hear about. And again, the ABI criteria there may be even higher. Now, can we revascularize everyone? And should we revascularize everyone? And the answers to both of those are no. Probably. There do appear to be about 20% of patients who get revascularizations currently who don't really benefit from them, and a lot of us have those show up certainly to our offices, our practices. These can be patients who are in nursing homes. They have exposed heels. They have critical limb ischemia, truthfully, but they don't ambulate. They lived in a care environment. I'm not going to present you that data, but the SVSQI data from New England showed this quite a while ago, that those patients in general really have no increased life expectancy or even quality of life by interventions. Yet families will ask you to do them, but you have to think, well, mom's in a wheelchair, she doesn't really eat, she doesn't interact, why should I do an angioplasty on this patient? Yes, I can heal her foot, but should I? And then about 15% of patients are not candidates for revascularization based on anatomy. Now, this number is going down and down and down, and it's going to continue to become lower as we do more deep venous arterializations, and you've seen a ton of the pedal work, and that number is decreasing. Interestingly enough, there was just a stem cell study trial that actually closed from the Pluristem trial, and in part closed because the patients who had critical limb ischemia, and it was to be used in patients who could only be not revascularized. And the reason it closed was that the patients who couldn't be revascularized actually didn't do as poorly as we thought they would. So hopefully that data will come out, because some of these critical limb ischemia patients that we think are going to get amputated in 6 months, we might tell the patient's family, it seems that they continue to do better, and that might be medical therapy. So I have to say we have a moving target of how patients with critical limb ischemia do. But we do know that if we can possibly revascularize patients, including patients with diabetic foot ulcers, and this graph is a slightly old one, but I think a valid one. It's just looking at 3 different methods of evaluating perfusion to the tissue. The square boxes are ankle pressures that we know are artificially elevated in DFUS. Toe pressures with the triangles, and TCPO2, which is cumbersome, but probably the best one out of this group for diabetic foot ulcers. As you improve these numbers, the patients get better, and this is pretty straightforward. If you get their ankle pressures or their toe pressures up into the totally normal range, they actually heal. So again, these are diabetic foot ulcers that may have a different criteria for revascularization than our standard thought process of an ABI of less than 0.4 or a toe pressure of less than 40. This is looking something different with this is skin perfusion pressure, which not every lab has. A lot of wound care centers have this, but a lot of labs don't have this. And skin perfusion pressure is actually a better indicator of the ability to heal. And so this is looking at a group of patients who had CLI, not specifically diabetic foot ulcers. And again, it just showed that there was a significant improvement, and you can see it becomes very significant. So sort of the probability, skin perfusion pressure that's in the sort of in the mid-range here, still doesn't heal that quickly, where the probability of healing approaches 100% as you normalize skin perfusion pressure. So these are the goals. This is actually what you're trying to do at the end point. And I think if I had any admonition to my cardiology colleagues that I still think is a little bit different, and I'll throw this out here. I mean, this is not a talk about doing bypass versus angioplasty, but I always think it's interesting that you guys do great work. You revascularize a heart, and they had a stress echo that was bad beforehand. I'm always kind of curious why they don't get a stress echo right afterwards to see that they're so much better. Maybe not right afterwards, but a week later. So after I do an intervention on the foot, that patient's back in my office within a week to have also an ultrasound and a physiologic test to see how much I've improved. Now, we're starting to do these point of care, and some of you guys probably have this, but using like near infrared spectroscopy right in the OR. We angioplasty, and then we look at it right then to see what the perfusion of the tissue looks like, and then we do it a week later, and it does continue to improve, which has been written about previously. So what are we doing about this? Well, this is somewhat old data too, but as you can see, endovascular interventions are obviously continuing to increase. This is 2006, and you can see this line is bypasses continuing to go down. And with that, however, with this increasing rate of endovascular interventions, we are seeing a decrease in the number of amputations being done. However, we're seeing an ongoing increase in the number of interventions. So I think one of the things to focus on too is doing interventions that have long-term benefit. I want to touch briefly on the angiosome concept. Now, this is a little bit cumbersome, but this is the idea that the foot is divided into 6 distinct angiosomes that are fed by various source arteries, and as Dr. Krishnan talked about before, the arch of the foot and the foot vasculature is very prone to microvascular disease. And the problem here is if you have a heel ulcer and you revascularize the dorsalis pedis with a intervention, percutaneous intervention, it's less likely to heal the hind foot. Perineal revascularizations are not that effective for healing forefoot lesions, and that's just true. However, a bypass to the perineal, interestingly, will help heal it. So sometimes when you really can't get the right angiosome, revascularize, a conversation between yourself, whoever's asking you to help heal this wound, and a vascular surgeon may be appropriate. Because there are times when you read the literature, you'll see revascularization perineal works for healing wounds. And then if you read that, that's actually works for healing wounds when it's a bypass. Revascularization of the perineal doesn't work for healing wounds. When you actually read the article, those are endovascular interventions. That's a generalization, but it is something to keep in mind. And this is just the idea. Now, there's a lot of sort of gray areas in the angiosome. You know, toes are obviously coming from dorsalis pedis, medial and lateral plantar ulcers, arteries, and not all of these are as cut and dried as you might think. But obviously, the bugaboo of all of us is the lateral heel for healing things, and that has a perineal flow. But the rest, the medial portion of the heel, which also gets ulcers and can do very poorly, is posterior tibial, and at times that doesn't have a good option for revascularization. However, a bypass to the perineal might do a better job than an angioplasty of the perineal. This is just a quick distribution of where the lesions are seen, distribution of arteriosclerotic lesions, and obviously the dark is the very high-grade occlusions of greater than half the length. And you can see that the perineal artery in general, as we all know, is relatively spared in diabetes mellitus. The tibial-perineal trunk is often spared completely in diabetes mellitus. The posterior tibial is spared more than the anterior tibial, and this gives us some hope and thoughts about having a good jump-off point for deep venous arterialization from a posterior tibial approach, potentially. I'm sure there are people talking about that here. So just very briefly, retrospective analysis of taking a look at diabetic foot ulcers with ischemic limbs. They're using the angiosome concept. They reported complete healing of foot ulcers with or without minor limb amputation in the majority, about 75% of limbs. So this is, in general, what works, but this is taking a look at direct endovascular revascularization, so actually getting the correct angiosome. And if you could get the correct angiosome, you had an improved overall survival of the limbs. And this also showed healing and preservation of healing. So again, if you can get the right angiosome, if it's a forefoot lesion, you'd really, really like to get yourself a nice dorsalis pedis. It's plantar midfoot. You can get the posterior tibial. And the idea is don't just take what is available to you. TCPO2s post-intervention are important and a good thing to do. This now might be in partnership with your local wound care center, et cetera. But the idea here is if after angioplasty, you really want to move their ankle brachial index up, but the TCPO2 increase is going to be more predictive of how that patient's going to do. And certainly percutaneous interventions are effective at this. So we're able to move this, but it would be nice to have that data after we do it. So endovascular first, determine the angiosome, revasc at all costs. If you have success, then you can debride and rebuild that critical limb ischemic wound. If you don't have success, possibly, you can't get the angiosome, it is a time that you might want to think about bypass to the best distal target. And with that, thank you very much.
Dr. Lantis, thank you so much for that. I think, one of the interesting things, let me just ask, is there any questions from the audience first? You talked about the functionality of a patient. If the patient is really bedbound and contracted, you may not want to revasc them. What about other indicators? Like you hear about Wi-Fi classifications, the degree of the wound, level of infection. Does that come into play in your practice?
Definitely. And we looked at this also during, obviously during COVID. I think a lot of us looked at our limb salvage practices and patients didn't want to come in and they did very poorly. And it's interesting data coming out from all the literature about that. But certainly the high-grade infections, the foot infection 3 category. Once you get to the 3 category, the Wi-Fi, which is a fulminant infection, your chances at limb salvage are poor. The reality, however, is a lot of the patients who have a fulminant infection actually don't have the really critical limb ischemia. So in that case, that's a case where you might want to try to manage that infection as aggressively as you can and then come back and fight the endovascular battle afterwards. Because that patient who's really sick from that usually actually has enough infection to become sick. I mean, that sounds silly. And I think all of you have seen this, but certainly you have a patient sometimes who have a forefoot wound that's somewhat ischemic. It's got some bacteria. You do a really nice angioplasty, atherectomy, whatever, you know, your technique du jour is. You do that, and then all of a sudden the patient has a fever, they get a leukocytosis, they look worse, their renal function might take a little hit. And in that case, you know, probably want to get the front of their foot off quicker than later. So there is a balancing thing. I think the big bugaboo is how bad the infection is. How big the wound is matters too. It is, in my experience and others, you know, the bypasses will heal a big wound faster. So you have to balance how big the wound is versus the patient's comorbidities. And at times, just the size of the wound, a big heel ulcer, for example, you know, you get a nice bypass in the posterior tibial, that thing will turn around and heal quickly versus an angioplasty, just because the volume of flow is somewhat different. So I think the quality of the foot itself does matter, but the infection is the key ingredient.
Thank you, Dr. Lantis.
Thank you
Thank you very much. Have a great day.
Next one.